yourself, that you make for yourself. And we've seen a lot of articles about the nomads that go around Europe and the world and just working from like on a constant basis and the freelancing and stuff like that. And I was intrigued by that. And so can I do this? Can I make a living from actually being working remote? And I'm on the way. I'm not really there yet, so I'm just aiming to actually get that in place.
What do you think about working from home all the time, though? My girlfriend is working from home as a daycare mom, and she, is always at the house.
Yeah,
and that becomes a bit tedious as well if you don't have any else to go.
Yeah, but I'm accustomed to living at home and being at home and working from home as well during the pandemic. I love that.
That was my follow-on question. Was the pandemic a place where this thought started to grow from a small thought to something that you took action on?
Yeah, actually it was. And there is a lot of discussion that, okay, can you actually work efficiently from home? Or do you just start a dishwasher, go out with a dog, rake the garden or whatever? But I'm into work when I'm working. And then maybe, of course, I put on a dishwasher now and then. But I want to do the efficient work when I work. And
so no problem with like self-discipline when working from home?
No, because my work never ends. I can still work when I'm sitting in the sofa, or I can being out on a walk and still work, because so diversified what I can do with my work.
Because not every person can do that. Some people get distracted and turn on a TV show or whatnot.
I'm super impressed by that. I need to be at the office.
Yeah, you do. Yeah.
I mean, like this is I've heard this conversation as well. I want to the opposite. Like I want to compartmentalize life here and work here. But on a deeper note, because I've been really thinking and dreaming about these topics. I lived in Australia for a couple of years, and I love to surf. We don't really surf here, so this dream of maybe I should have 3 houses and 3 offices, and and just move with the. So that whole thing has led me down to a path where I really want to ask you now: have you kind of starting picking apart your process or your systems, or how can I make this work? I need to have a very good connection. I need to have because the technology is all there, but it's also to make it work. Have you thought about the ecosystem for this to be efficient for you?
Yeah, actually I have. The house that we are going to move into, it's an old house, and actually a big hallway, and there's a spot there that here's my home office. But I can't use that home office if there's my little 7-year-old is home. So, it was the alternate office. So I have like a smaller, like a guest house. And, here's I can have my other
all this. This is super important for this to work.
Yeah, exactly. And also some of the other living bedrooms that actually can have like here I can do some real work.
And are you limited, or are you needing of any technology in terms of really good connection?
Yeah, because
video conferencing.
Yeah, video conferencing. I need to have that. So like a good Wi-Fi connection, or it's fiber in the house. So it's not that big of a problem now in Sweden.
Yeah, because you can take that whole thing to the extreme. How can we make our video conferencing be less stale, and how can we get it more engaging? How can we go all the way into the technologies where we sit in the room, So there's a lot of technology and the whole metaverse conversation. You can go down this rabbit hole if you want to, but I don't know. For some people, or for me, I think it's to find something that really works, but then also to find where is the limitations when we are not connecting as humans, and how can we make those limitations smaller and smaller and smaller. That has been an intriguing thought process for me. Have you thought about this?
Well, in a way, yeah, because I'm always wanting the technology to work for me, not against me.
Exactly.
And that's one way to do it. So I can actually use the technology to actually make me work from home and have the internet connection actually working, and the video conferencing to be well, you don't have to have a background that's blurry and stuff like that. It's okay to have a real calm background that, it's neutral, and also see that you have a good. The audio should be good, and you should be comfortable in the situation. I see a lot of patients via video, so that I can actually see them from all over Sweden or wherever they are. Of course, I have some patients that, they went on a business trip to the US. And so the time difference, we worked that out. And then we had a video conference. And
do you know the place called Mr. Hult?
Mr. Hult, yeah.
Yeah, okay. Very close where I lived.
Yeah, I did. Okay.
But anyways, it sounds like a big life transition in some way to Västervik then, for you.
Yeah.
Yeah, I think that sounds like exciting times, I think.
Hopefully, yeah.
I didn't know you had this whole holistic side to you.
You should be surprised.
Yeah. Full surprises.
Best of luck on that kind of transition and move towards the what we call
the metaverse. Living anywhere,
countryside lifestyle, working from home.
The next generation of living and working. I think this is something that we will see more and more of, and finding this not only one way.
And perhaps AI can enable this for more people going forward as well.
You can imagine.
Definitely. Anyway, with that, I'd love to welcome you both here. First, Carl-Fredrik Swic, is that the way to pronounce it?
Perfectly done.
Yeah. Founder and CEO of a company called Mediqtech, is that?
Yes.
Yes. Yeah. Awesome. And also, very welcome here, Kenneth Ilvall.
Close enough. Ilvall. That's a terrible way to pronounce it because it's so hard, and it's even worse in writing.
But you're also the Chief Medical Officer then.
Yeah.
And as you may then guess, we're here to speak about how AI potentially can revolutionize healthcare in different ways. And you have a startup here which have done some really cool stuff. And it's also a field that I know you, Henrik, have a lot of passion too. And actually, I've done a lot of medical kind of projects as well. What was it? We did we heard on the morning news recently about how AI can be used to diagnose breast cancer, for example. And I worked with a brain tumor case a couple of years back. We actually did one thing where we tried to predict if they prescribe antibiotics in the dental care by looking at journals at one point. It's kind of fun. And
I have had an ongoing conversation with my father, like you do, for maybe 10, 15 years on how to innovate and use data and AI in the hardcore profession as a what do you call it? A children's surgeon,
pediatrician.
Pediatrician. Yeah, and he was then at some point heading up the pediatrician surgery in Drottning Silvia. 200 staff, and then dealing with the bosses and what that means, and dealing with the real operations and how to bring data and AI into this context. So this is an ongoing conversation on the madness and the difficulties and what we should be doing and why is it not happening.
Yeah, AI can really revolutionize, I think, the healthcare. So I'm looking forward to hearing more about your approach to this and what you're doing there. But before that, perhaps Carl-Fredrik Swic, if you were to describe yourself, what's your background, your passion, how did you get started with Mediqtech?
Oh, yeah. Well, my initial background is economics. I studied international sales and marketing and international management, and was on a road to just work more with that. But from out of the blue during the summer, a really good recruiter called me and pitched going into recruitment for medical professionals, especially doctors. And
medical doctors.
Medical doctors, the medical field in general, but specifically like recruiting doctors. And I got stuck. Sounds so bad, but I was in that field for over 6 years. And
recruitment for medical doctors, basically.
Recruiting. If you have a hard time finding a doctor to your clinic or hospital,
interesting.
Yeah, there was the part where I came in and tried to find the right person for you. And in the process, we talked to so many doctors and the bosses of doctors, and like what can improve, what is the reason people leave work and take work, and what all these kind of things. So for 6 years, I was basically the what do you call it? A person you empty out your work problems to.
You were the therapist. You were the therapist. I know that.
Yeah. So and people who are unhappy about their work love to talk about it. So and all the problems they brought up during this time led to the start of Mediqtech with our colleague Jamal, who was in the same company as me, and we started talking about all the things we hear. How can we take these problems and solve them with the race of the beginning of the AI bubble, or the AI's boom, right? Rather.
Cool. And why did you get started with the Mediqtech? How was that specifically? Because it's not really in recruitment that Mediqtech is working.
No, it was just all the problems we heard, like all the problems regarding the administrative work that doctors have, and nurses as well, and all medical professionals. So much of their time is spent on doing non-patient work and things that can be done by AI. And Kenneth here knows that even better than I do. But there is this the reason why a lot of people leave their work, and why people leave there, because you can see there's a big escape from healthcare. A lot of doctors want to leave their work, and a lot of young doctors in special leave the field. And we were wondering, like, why is that? And a lot of the research to why people leave is because they are overworked. And it's not really what they expected when they got into medicine from the start. It's very administratively heavy. Yes. And you spend more time sitting on a computer typing than meeting patients and doing a difference. Yeah.
My mom actually worked as a nurse as well, and I remember when the whole digitalization of journals started, and she was so frustrated and thought it was horrible, and she hates anything having to type in these kind of horrible UIs that these kind of systems have. But let's not go into Mediqtech yet right now, but it's awesome to hear that is something that you're trying to help with, and partly revolutionize as well. Before that, then, please, Kenneth, can you just describe who is Kenneth? What's your background? How did you get into the field of medicine?
Yeah. So long story short, I was out on a round the world trip when I was 20, and I realized that I was actually good at massaging. Mm-hmm. So when I came back, then
where is this going?
You'll see.
Yes, exactly.
You'll see. That was a good trip. No, actually, when I get back to Stockholm after the trip, I decided I wanted to do something about it. I educated myself to be a massage therapist, and actually have a small company with that, and just went up to businesses and companies and doing the massage of the employees. Which actually the employer paid for. So that's quite lucrative, and I realized I could do something good with my hands and the treatment there. And after a few years, I decided, okay, I can do something more. I need to do something more about this. And then I went into med school, and I still wanted to help people. That's the way I was. Well, that's the drive for me. And during that time, I actually realized that, okay, I'm a bit of an entrepreneur as well. So I wanted to do something else, something new, and to start businesses in some way. And when I was almost ready as a specialist in general medicine, then, okay, there is an opportunity that went up. And so I can actually start off Healthcare Central, Vårdcentral in Swedish. Which was quite lucrative, and we opened another one, and in that time I came across the video meet, the Kry, Livy. Yeah, they approached us, our company, and they wanted to us to be the caregiver for them to actually have the medical thing.
And that was a company that you had started at that point, or was?
No, we started to care. That's our healthcare. To care
was actually Vårdcentral.
The Vårdcentral, yes.
And here you have a collaboration now with Kry, who is the digital app.
Yeah, and we wanted
can the content they need for that app has to at some point connect with the Vårdallmänläkare knowledge. No?
Correct. And I was the recruiter for doctors and just learning teaching them how to actually do a video meet and what to not do and what to do, and also do all the medical background from them in the beginning. So I actually did that for 2 years. And then I realized, we have to do something more. And so I just skipped that and just went on in my general work. So, and I did a lot of other things as well on the same time, but
you got a very detailed insight on one of the first sort of digitized startup ideas that actually has kind of worked. I mean, like what Kry is doing and Doctor.se and these guys are doing, they found their place, they found their niche, and I would argue they are by today quite established.
Yes, I would say so. It's in several countries.
In different ways. But you saw that business model and, the back end of how this business model needs to work.
Yeah.
So that's interesting, right? That's a learning that you can bring with you now.
Yeah, of course. And also other companies that actually went from nothing, just a dummy, and up to Mediqtech. So there is a problem here.
The confusion.
Confusion when I'm referring to my companies that I've been working on. So Mediqtech, that's a digital caretaker that have been. Well, their business model and the vision was to offer specialized care to patients without any referrals. And they will skip the step of have to go to a healthcare center and get a referral to a specialist and then wait for a few months or half a year or something to see a specialist in maybe a gastroenterologist or a skin doctor.
How to make the flow to the specialist way smoother.
Yeah, so the founders of that company, they wanted to have a health plaza that you will connect as a doctor and you connect as a patient and just meet. And it worked. And I did all the background for that and all the trip that the patient have to go, the pathway.
The customer journey through this, the patient journey.
Exactly. So that's what my goal was in that company.
Well, that leads us to, I think, the big question then. At some point, both of you, or I'm not sure, was it you, Carl?
How did it get started?
Mediqtech, or how did it get started?
Yeah, the initial start was me and our colleague Jamal Sharif working together as recruiters. And as I mentioned a little bit before, started to talk about all the things that the doctors were telling us. These are the problems they're facing every day. The reasons why they want to take an assignment, take a new job. So all these problems that we hear, because a big part of the job was just to connect to doctors and speaking to 30, 50 doctors a day, you will hear a lot of problems. And so Jamal, more than me, was the more tech savvy. And we started talking about with the initial boom of AI technologies and when ChatGPT launched, and how can we use the power of AI to solve these problems?
So this was at what year? 2023 or 22?
22.
22. So right when ChatGPT basically launched.
Yes.
So had you seen ChatGPT when you launched, or did
we didn't. We were pre-ChatGPT.
Pre-ChatGPT. It's also interesting because immediately you need to think about, how do I now understand the thesis? Could you summarize down what was your, if you go back and now we know it's pre-ChatGPT. So, but what was your
by a few months perhaps?
Yeah, but still, in terms of the how you have opened up your mind to maybe what is the art of possible here. What was your founding thesis? What was the core problem or thinking that, because all this stuff shows there is an arena for improvement. But then, how did you articulate in your heads, you and your partner, when you started, we're going to go after this big, hairy problem? What was the founding thesis that you, was that more evolved? I mean, it could be that case as well, I guess.
It's a really good question, but I would say one of the big problems that we found that doctors have is finding information, and it's such an easy problem to fix. A lot of doctors spend a lot of time searching for information, especially we have a lot of Swedish healthcare is now dependent on locum doctors. I'm not sure. Hyrläkare. People traveling around Sweden to where there's problems to recruit, and to travel from, if you have been working in Stockholm your whole life, going to another region, it's not a big country, but there's a lot of differences between the regions, and there's used to be a lot before, especially when we started working 6 years ago with this, way more journal systems, and because now there's one who is basically taking over the whole of Sweden. But working from one system was very different, and there's different regulations, and there's different just aspects of working in the regions, and finding information is hard. And you have all these. You are expected to come into the workplace and just deliver from day one. The first thing from the start. And how can we make it easier to find all this information? And
so knowledge discovery in some way knowledge discovery or information retrieval kind of purpose to start with.
Yeah, as a specialist, the word for what's it called in English?
Say it in Swedish.
Yeah, allmänläkare or general practitioner. Yeah, exactly.
GPs.
The GPs. The word itself is kind of, we talked about it before, it's kind of contradictory. To be a specialist in everything is hard.
It is.
It's really hard, and you can tell us all about it.
I think that it's a contradiction in terms to say you are a specialist general practitioner. I mean, that's
no, you're a specialist in how to be the most efficient in the GP role.
Exactly. Well put. So you're a specialist in how to most and if we flip that into I would summarize that. Okay, so you want to, one of the founding theses is how can we make a smooth onboarding of GPs, for instance, when they are in a higher contract. So how can I get the time to market for them from I hire them to they actually can do their job 100% without asking stupid questions to everybody. Along the way.
Along the way, right? So the onboarding process of a GP in a new setting, for instance, hyrdoktor. What is the English word?
Locum doctors, I think.
Locum. New word for me.
Yeah.
Like contract, but it for me it's like the whole contracting around doctors.
A different word for it. Yeah, consultant doctors.
And it's typical. Yeah. We have a lack of enough skilled resources in one region.
Yeah.
And we have a really hard time getting permanent employees. So we need to solve it in some ways.
Yeah.
Cool. Do you have a mission or a vision for Mediqtech? What is outspoken or?
Well, you are the wordsmith. Kenneth is incredible of summarizing.
Well, I will have a vision for you after this.
We should ask ChatGPT otherwise.
We did, but it wasn't that good.
How did you? Okay, so I'm just going to ask Kenneth. How did you got intrigued, and how did you guys meet?
I was lured.
Yeah, how were you lured? Tell me that anecdote.
We're salespeople. We lure.
Yeah, you lure. No, exactly. Yeah, I've been actually meeting up with Jamal in some other aspect, and he said, okay, you were like a front-end doctor, and you really lean forward to the new technology. How do you like to have lunch with me and Carl? Yeah, okay, sure. I'm game. So we had a dinner. Dinner or lunch? I can't remember.
Whatever. It was a dinner.
Yeah, dinner. Yeah. So that was nice. Yeah.
But in short,
sorry. Yeah, sure. And then they discussed the the problem that they saw in their former roles, and I was intrigued by the idea of actually getting better information and better teaching possibilities for the doctors to actually, well, some of them, the locum doctors, they were maybe right off the medical school, and they don't have that much experience, or they lack the experience from that region that they were working in, or that field maybe. So they needed some guidance and some help with tutoring. And I was intrigued by that because I worked as a studierektor. That's some strange word for that in English. Yeah, it's not, well, some things it's completely different. Yes. But that's actually someone who actually teaches, and not teaches, but helps the intern to actually get through the residency. And
the principal.
Yeah, well, not the principal really, but anyway,
associate principal.
There's a regional something. Regional director is the English. Yeah, regional director. Anyway, so I have the knowledge of the problems that a doctor who's not really comfortable in their role yet, and maybe they need some more knowledge in some fields, and those guys are looking at a bridge to help those guys out there. And so I was intrigued by that.
We wanted someone to take all our crazy ideas and kind of be our filter, so to say. Someone, we started talking about like a lot of different solutions. What are the most effective, and what can we realize, and where's the technology, and what is the actual value for the doctors. So the
pain points as well.
Yeah, and the first embryo of Mediqtech was, okay, all these doctors out there, how can we test their knowledge, like they do for pilots, for example? In order to be a certified pilot, you need to constantly renew your pilot's license. And doctors don't.
No.
So was that the first use case, or what was the first product you tried to develop?
That was the first use case. Like, how can we see if the doctor is at the knowledge base where they should be, and not to get them in a gotcha moment, but more than to focus where can we? Because there was a lot of complaints about there's not enough time for foot building to.
Continuous learning.
Continuous learning and further education. So how can we more effectively see, okay, where are the lacks in the knowledge, and how can we pair them with the right courses in order to more effectively make the regions put their resources into the doctors.
Interesting. So more like lifetime, learning and having them upskill themselves.
Yeah, it's a lifetime learning. That's what we do.
But it's a lifetime learning, but it's also a little bit like, okay, in order to put the plan together, when we onboard this doctor, we want to know his strengths and weaknesses, and where is the most bang for buck. If we give it, where should you go and read? Where should you go and study in order to excel in this region, in this set context?
Yeah. And I also discussing about how the doctors then has been out there in the suburb or in the remote areas in Sweden. And how can the manager of that healthcare center really know that they have done their shit?
Yeah.
Has they really done what they should do?
What do they know?
Yeah, and what they know in advance, and what have they done afterwards. So if there is anything that they have missed, that was also something that we discussed. Yeah. So like a support for them.
Mm-hmm. So did you sell this somehow, or how did they, how did you go about?
This was very early in the thought process, and we discovered that doctors doesn't like to be evaluated.
I can guess so.
Yes,
I would take offense as well. Yes. I must say.
Yeah, but it's interesting because, for example, you want your pilot to be up to date about the plane they're flying and all the rules and regulations. And we thought that, we were young and naive, and we thought that, so does doctors. They want to know where they
Not in
lack.
Sweden.
No, not in Sweden. Doctors don't want to.
But maybe the regulation came first, and then the culture changed.
Yeah, there's a regulation in Norway, for instance, that all the GPs have more or less renew their license every 5th year.
Which is similar.
Yeah, but in England as well as
a lot of countries in Holland as well, and Netherlands.
And then I think that sort of cultural blockage will go away.
Yeah, but there is not sufficient political muscles or gut
in Sweden to get it over.
to get it.
But then you move forward in some way, right? And you got and started with some other use cases.
Yeah.
Right. I heard something about Luna or Maly or which one? Any of those that you like to go a bit more in depth with?
Yeah, I'm going to start a bit because when we started to figure out because there were so many ideas, there's so many use cases, and when we got the help of Kenneth, like realizing and pointing out like what can be actual value, because you're not only a doctor, you have been running your own clinics and studiedirector and all these kind of things. And running your own company, you have a wide set of skills that we saw as very useful for us, and therefore the approach and So what's the word I'm looking for?
Is it Luna you're speaking about right now?
Yeah. So we wanted this to see like what products can actually be used, not just our young and naive thoughts about how it should be, what can actually be done. And Luna was one of the first products we came up with. And
so what is Luna?
Yeah, it's information search basically. So how can you more easily find the information you're looking for in the region?
LLM RAG solution in some way, or how would you describe it?
When ChatGPT came, we explained it as ChatGPT for healthcare professionals, basically. So if you're a what's it called? I keep forgetting the word. Allmän specialist, GP. If you're a GP, like how can you be updated in all these fields, and how can you, as a young doctor, when you're on the beginning of your journey, how can you be a less burden to your colleagues? How to not interrupt workflows? How can you be more efficient by yourself, and how can you without disturbing the other doctors? Because that's one of the things we saw. Doctors need to go and ask the other doctors, the even more specialized people, and there are 3 different stages of being a doctor, I guess. At that time, when you first you come to med school, and then you do your studies to become
internship, and then the residency.
Yeah, and the residency, then you're specialist in the training to become a specialist, and during this whole process, and even seasoned doctors need to go and ask other people, hey, what is this? In order to more effectively to make the workflow more efficient.
So what kind of information sources are you using to?
Everyone. Yeah, but that
sounds a lot.
No, of course, that's not
decompose it.
Yeah. So in every region you have something called beslutsstöd in Swedish. Decision support. That's the direct translation, and I think that's what it's actually called.
Proper support.
Yeah,
proper translation.
Yeah, and you need to know what the actual decision support is for every different diagnosis or every different symptoms, but you don't. So then you need to have someone or doctor's companion in exclamation points that you actually could rely on. That this is the most efficient and best information that I have at hand at this time.
And here maybe, correct me if I'm wrong, but it used to be nuanced. What is that decision support, and what is the preferred best practice procedure for a certain is different from region to region.
Yeah, it is.
Depending on where a certain hospital has gone and what they have trained on and stuff like that.
Yeah.
So that's why this decision support needs to be contextualized with the regional context or the law of the situation of that region.
Exactly. And that's
so now we have an information problem.
Yes, of course. And you also, there is something that's called national guidance of a lot of things, and you have to merge those two together. And then, then I have this is the best practice for this patient in this region at this time. Yeah. And this changes, of course. So you can't really drag along with you a book. A doctor's companion was and is a really thick book, and then you have a smaller version that's this leaf-thin pages. And so,
with the changes every week or every month or every year.
It should actually. That book actually changes every year, but it should be changed every month, maybe. And this is hard to keep track on that. So that's why we created Luna. And so it will scrape down every other aspect that we have out there in the regions, and you can pinpoint it through each region.
I fully see the point, because it's one thing not only to make this once, but it's to do a framework or a template or the platform around it, so you then can fill it with the local regional best practices.
Yeah, and then it has to learn from it as well.
Yeah.
So you fetch and scrape data from the web in some way, or where do you find the information?
Well, the regions have their sources they want all the doctors to use, they practice in that region and in Sweden. So basically that.
So when we say scraping, we are literally going to every single different department that has their policy and their practice, and they're not always one-to-one connecting to each other, so they make sense together. There's one can be an anti-pattern for the other ones, but in practical terms, you will have practices around anesthesia, around surgeon, blah 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 blah, and then you will have practices around how the administration, so that you need to go to another department to find their policies and stuff like that, and all that becomes a whole. That's the soup that the doctor needs to navigate from administrative best practices to treatment best practices in the context of a certain hospital technology, etc., etc., etc.
Yeah. So that's in a nutshell. Yeah.
In a nutshell, right? Mm-hmm. So this then is what scraping is all about: to go to all these different sources and then.
Mix it together and try
organizing
to answer the question at hand.
Yeah. So do you train a model on that then? Do you scrape the information? Do you retrain or re-index in some way the information? Or
it should be, well, the work is ongoing, and we need to make it even more efficient and more accurate. And the presentation is everything. How do you present the information that you have gathered? There is a decision support or a decision suggestion. So that's a big difference, actually.
Is it like a ChatGPT interface, or how does it look right now?
Yeah, basically. Yeah. That's how we wanted it to look, because people started using ChatGPT to, first people started doctors using Google, and took them so long to look for symptoms and guidelines in all these different systems. So we wanted to take all these different systems and just combine them into one because there was we heard that a lot of patients were very upset about the doctor sitting there Googling your symptoms. So having a system that looks more, good, no, it's a bit worrisome. And how can it look more professional and make this whole process easier?
So give a concrete example. Is it when someone makes a diagnosis in some way and they need to basically confirm or give some kind of support for why they did this, or what? Can you give some kind of concrete example? Yeah,
maybe we have a patient that's tired and have a fatigue problem, and so then we do some blood tests, and have 10 to 15 markers that we need to check on, and then the blood tests come back. And then we see the blood test and say, B12 is low. So what is the decision making for this region of B12 deficiency?
What's the treatment plan?
The treatment plan. Yeah. What's the next step? Do I need to have a endoscopy? Or do I need to just treat them at first? Or is there any other...
So there are two major steps. One step is to help establish diagnosis with the highest accuracy. And then
is it mainly afterwards, or is it even before you do the diagnosis?
Well, before actually.
It's more before.
Yeah. Maybe you don't have the diagnosis. Just to say you have the B12 deficiency. Okay. But why?
Yeah, this is what I mean. So you have someone is coming in and having a pain or something. Then you want to put the diagnosis in where you want to go to the root why. Yeah. So this is the process. What are our best practices on how you establish the why for the sickness? And then when you think that we are now happy that this why is strong enough, what is our region's view on treatment plan from here on? What do we do first? Do we do more tests? Do we get them on these drugs? Do we refer them to another specialist? We don't have any money for specialists. We give them drugs at once.
Exactly.
in some regions, right?
Yeah, correct.
And which in other regions, it's like, no, you go to the specialist now.
Yeah. So that's the next step.
This is the next step. Yeah. So you have the whole process of taking and setting a diagnosis is from original symptom to diagnosis. What is this best practice? Yeah. And then you have the treatment plan according to the policies, the money and experts available in that region.
Yeah.
Because also ICD codes, medicines, all these things that is impossible for one person to have in their head. You don't need to have it in your head. You can have it in Luna.
At your tip of your hands or your tongue. Yeah.
But let me clarify one thing, because as I understand it, it's not that simple that you can use to load this up once and then go with it. So this has to be a platform where you dynamically can input the information that is the correct information to look at from this region, and also adjust what treatment plans is the correct one. So you need to be able to interact with what this information. It's not as simple as just uploading everything once and then you're happy. It's very dynamic.
It's dynamic work, and we talked about the engineers about this, and okay, how long did it take to scrape everything? Oh, maybe an hour. Okay, so the algorithm was there. So you can do it actually every month, but every week if you want to. So we can have the exact information.
Because then you get to the product view on this, because ultimately then, in order to install Luna, you need to install the practices of filling the data in, updating the data on the one hand side, and what is the UX for this and who should be doing that, versus the UX for the doctor that makes it usable and adoptable in his workflow.
Yeah. Well, yeah.
Are we getting it?
I think you're getting it. Yeah.
It's a super good idea.
Yeah. Thank you.
We think so.
It's an awesome idea.
Yeah. Is it used by anyone today? Or is it more in pilot stage, or is it what's the current status?
In the learning stage. So we have the template for it, and we have trained it a bit, and now it's in the working space that we want to put it to market in some way.
Yeah.
Do you collaborate with any institutions or hospitals, or how do you?
We work with a few local private clinics that are able to test the things we want to. Yeah.
Some sort of alpha, beta client.
Yes.
I think that would be smart, right?
Yeah, we have discussed it. Okay, so we can have one private driven healthcare central. We have some regional that actually have to get reimbursed from the region, and also some larger hospitals and stuff like that. Can they use it as well? So,
do you foresee any challenges in putting it in production properly, so to speak?
Well, what you put in, it's what you get out. So if you ask a question that's not really on point, then you get a lot of answers that maybe are a bit diversive. But if you actually can make or learn how to really put the right questions, then of course the database will answer directly what you want to know.
So you need to onboard or upskill or learn.
Yeah, well, I think
training sessions.
Yeah, training sessions that could be good. But I think you will learn efficiently how to ask the questions more properly, and depending on what you want to ask. If you're like an ICD code, and okay, what's the ICD code for this? And then you have three different alternatives. So that's easy. But if there is a more complex diagnosis, then you have to maybe ask 4 or 5 questions to actually get to the point. And then, okay, there's a more complex thing. But the model will actually are capable of getting that to work. But we will see how it will in actual life
cool. Yeah. What's
function.
What's the next steps for Luca?
No, before you go there, the challenges. I think this is a good challenge. I can relate to selling this in relation to selling data and AI for different reasons. One thing that you need to crack is that obviously then for making this vision to work, you literally need to sell it to several different actors. You have several different change agents you need to line up to get commitment with the guys having the right information that they think this is a good idea, who is going to continuously dynamically update it and keeping it track because they need to go 360 around the whole hospital. And then you need to convince the practitioner or the bosses of the practitioner. So you have like a user buyer, you have a technical buyer, you have an administrative sort of. So it's so to crack the code on how to communicate and sell that and how to make it easy. Like you can do something that looks great for the doctor, but it's shit and creates a lot of work for everybody else. Yeah. You see what I mean, right? So this, am I on point here that this is a tricky one?
Yeah, that's the challenges that we see as well. Because when we went out and just look at the market and who's going to buy this,
exactly.
Who want this? Everybody wants it. Looks nice, but okay, have you tested it yet?
And who needs to be on board and do their part?
But it's also about the value and also the perceived value of these kind of products, because there was a study in the US a while ago. I'm just reading here from a note that, and it's kind of what's the word? It's kind of telling for the general perspective of doctors in what these kind of AI solutions can contribute. And it said the headline was the doctors have no use of ChatGPT. Because the study showed that, doctors who used ChatGPT in the reasoning and diagnosis didn't perform better than the ones who didn't. But then it showed that ChatGPT performed better without the doctor. And
I read that article. There was a nuance on there that, we have, this is how you look at bias and how you look at your old things, that actually when you let it be, it does all right.
Yeah, and that's the thing, and the conclusion was as well that from the scientists or the researchers themselves that you need to optimize the interaction between with man and technology, and that was the problem. They found that the prompting was mostly the problem, not knowledge of ChatGPT.
I guess it's not only AI that needs to be trained; it's also the human that needs to be trained.
But that's what I was talking about the perspective. Of course, if you don't use the tool right, the tool is not used to you. So you can always say that, this is not going to help us, but if you're not using a hammer to hammer in the nail, if you try to screw it, try to screw something with it.
But I get an epiphany listening to you guys now.
Okay.
I think what you are trying to do puts a finger on a microcosmos of what is the real challenge on a macro level to get this to work with data and AI in healthcare in general. Because what you're describing now is that if we can get 1 + 1 + 1 + 1 working together, that becomes 10.
Yes.
But if I can't line up these things, if I put one of them to 0, the product is 0.
Yeah.
Yeah.
So the core problem is like we're working with data and AI as a multiplier effect, but then you need to get the data right, the operations right, you need to line up all the ducks in a row. And if one duck is not playing along, it falls apart. And I think that's the challenge when we get into these topics of, we want to do AI in healthcare. And we take a very simplistic view of, is the ChatGPT interface of the doctor? And we focus all on that. But we're not talking about the 360 view of what the other guys needs to change for this to be so beautiful.
No.
So do you see what I mean? Like, so just studying your case and studying how do you sell it, how do you make the product out of that, that actually tells us a lot about why this is challenging on a macro scale. Do you agree with that?
Yeah, exactly. That's
it's a microcosmos of the fundamental problem.
But now the fundamental problem, that's the stiffness of healthcare, and that should be stiff. It should be fluent.
It should be safe.
It should be safe. I think that's the general idea. So when we do changes, and come up with new things, it has to be like a filter and a stop sign. Okay, is that really safe for my patient? Is that really safe for my employees to use? Is there going to be a problem? So I remember when we, in a way, we have the journal on net. So like the journal is in on internet, 1177. It was a lot of discussions before that came to play. And I was on the Medical Association, and we had a hearing and talked about this. Okay, how can this work? And lots of people, okay, this is going to be a roar in the community. It's going to be, the doctors will be totally swamped with questions from the patient when they read the journals. But I said, why? Because if you write down the journal as it was, and you decided in coherence that, okay, this is what we have come to agreement on, that, okay, you have this problem and you do this, and then I do this. What's there to be alarmed about? But I think, and then I thought, okay, this is a fear of not doing the right thing at every time. Okay, so when we go 360 on this, so when we do the journal correct, and what will make the journal then? So I was just saying that it all starts with the journal. So if you put in everything in the journal correctly, then hopefully as well that you have thought about it correctly and thought through every aspect of it. And then when the patient reads it, okay, this is what we were talking about. So, and he got me right. And then he did this or she did this. Okay, so that's the one thing. And can we then help the doctors to put in everything right and also have a filter through it so it actually gets right every time? And also the information should then afterwards be
available.
Yeah, available. And trustworthy.
Trustworthy, available in the safe way.
Yeah, and then we have another thing that we wanted to do as well. We wanted to make the administration better. So we have some other tools in the line of getting that working even more efficiently, and also have the a journal. Journalgranskning, what way we have talking in English? Have you another word of?
Journal review.
Yeah, but journal scanning.
Journal scanning, yeah, that's a good thing to say. Yeah, so journal scanning is the other way to actually get everything. So see to it that every doctor has done. Well, it's
now you're getting into the next product, right?
Yeah,
Before we go there, perhaps just speaking a bit about, okay, you have a certain state for Luna right now. What's coming up next? What's happening there? What are you working with
for Luna specifically? Or
yes.
I think the Luna as a product is pretty much done. It's one of the first core aspects.
I get really scared when I hear someone say a product is done.
Yeah, but
ready for market.
It's ready for market. I would like to say it's under. It can always be better. The technology always has changed a lot since we first started.
Yeah, just during these 2 years.
From day to day.
More or less.
So when we wanted to, because like a lot of companies, we wanted to de-platform. We saw so many ideas that we can help, and we like one thing leading to another. And Kenneth put us. Obviously, you were responsible for putting us in the direction of, okay, what is the core problem, and therefore the core solution. You started talking a lot about the importance of the journal. Where is the information about the doctor writes down about the patient? There's so many things you can find, and it's very important for the whole medical journey for that patient. And therefore we saw that this is just a great product we can have as a part of the verktygslåda, the toolbox. And therefore we started talking about, okay, so where's the other problem here? Where's one of the most effective way we can actually solve? As we talked about before, the main mission from the start was how can we make doctors and healthcare professionals better? That was kind of the mission from the start. How can we help them be? I think you put it, you phrase it as
the best self.
Yeah, every day. How can we make the doctors their best selves every day? How can
improve productivity and quality and so on.
Yeah, because there's a lot of problems in healthcare, mainly due to there's being too few of you, too few doctors and few nurses.
Just a quick question there, because I think you mentioned journals as well, and for Luna, is that actually indexing the journals as well, or is it mainly the information about the policies that they have in the region?
It's like
the last part. It doesn't index.
Because otherwise you get into a lot of security, concerns, right? If you actually do index patient data as well.
Yeah, there wasn't any patient data in that part. For Luna, it was just information search, basically. So how can we
advanced?
Yeah, So how can we make the doctors more efficient in this particular aspect? So finding information. It was a big time thief, basically.
But do you have something ready for a more upscaled? Is it like a pilot, or is it what's the next step potentially that you think Luna can be up for?
It's the product is done. It's
ready to use.
It's ready to.
So now it's in go-to-market phase. So now it's like, how do we now sell it? Product.
No, it needs to be piloted. I think
piloted.
That's the next step. So
because you can't say it done without having tested it.
No, they have to be tested in real life. And
then it will continue to iterate, I think, a number of times before it actually is.
But you're really you're mature for proper piloting.
Yes.
And in reality, like if someone is listening, is intrigued, pilots wanted.
Yes. Yeah. Of course. Yeah.
Should we move to the next one with the interesting name? I like Luna. It's actually the name of our dog at home. So but I guess Luna is a very common name for things. But you have something called Maly.
Yeah.
What's that?
Well, the name is just a very funny and creative part from my side, because we wanted to see how because we had this person in Swedish healthcare called Maly, or medicinsk ansvarig läkare. So the doctor, or also the equivalent nurse. So the person who is solely responsible for best practices being used at the hospital or
at the unit, at a certain unit.
Yeah. So it's a wordplay of Maly, and Maly is making it a person, someone you can rely on, making it more a tangible.
Malin.
Yeah. Yes. Make it more humanize it, so we don't have this stiff-sounding robot.
Yeah. So here you have Maly is for the Maly. You're doing something for the Maly.
Yes. So the Maly is responsible for that everything is done right medically, and that's what we wanted to help that person with Maly. How can we help that kind of person in their process? Because the Maly today has and this is something we spoke about a lot about. They have a task it can't be done, basically.
No.
They are. You can speak more about like what they do than I
Yeah, I can. Yeah, but because the responsibility for the Maly, or now they changed it actually to MLA, so that medically leading responsible doctor. Yeah, so MLA, so ledningsansvarig in Swedish. And they have a responsibility to see that every doctor and every healthcare professional in that unit has done its stuff, according to the regulations and the policies. And how do you do that? Yeah, they have the journal editing, auditing, and they take like 10 journals and for a month and check. But that's 10 of several hundreds of journals. So how do you know that this is the golden standard of their own practice.
So now you're doing some sort of spot checks, eller säger man stickprov.
Yes.
Today we do, what's the English word for stickprov?
As randomized testing.
Randomized spot checks,
Yes.
as a way to get a statistical view of, every time I do my spot check, does it seem to be on point?
Yeah, on point. Yeah, and the thing is that if you look into 99% of all the journals, you miss 1%, and that could be the 1% that actually they did something wrong or didn't do anything that they should.
In a way, you would with algorithms and statistics and other ways of doing it, you could actually in a way have a signal system when things are out of sync, and you could actually have this on every single journal.
Yeah, so that was the general idea of it. So that if you can actually look at every journal that this particular person has produced over 1 month or what period that we choose, and then we can see if there is an aberration in some
anomalies or deviations.
Yeah, some deviation from the algorithm that we have put in this. Okay, you should do this.
Automate journal auditing, is that
journal auditing? Yeah. So journal auditing, and also the presentation of if there's a pattern. Okay, so every person that with diabetes sent off for the referral directly. No treatment. So referral. Okay. Okay. That person needs to be trained in diabetes care. So that's why we have
So the goal is really to try to judge the medical doctor to see if they write the journal and do the proper diagnosis in some way.
Yeah. In the first case is just to flag up, okay, is there anything that is patient hazardous? That's something that you need to address directly.
For the sake of the patient.
Yeah, that's okay. That's the first mission of it.
Yeah, but it's very simple, because you have someone who is according to law in Sweden and regulation, you need to appoint an MLA.
Yeah.
And this MLA has the impossible task to be accountable, to make sure that to govern that we are within our practices and policies, and we are following that to 100%. And in reality, they do stickprov as a way to, I haven't found anything bad, so that means we're good. How can you basically make the work of the MLA better? And doing the right thing, but also helping them with the data, the whole data collection and the scanning, and it is an impossible task to do for one person. At hand, manually.
So how does it work?
Well, the tool go through every journal and see to it that has it the flow. So you have a problem firsthand, then you have an anamnesis that some history of this is the problem that we have discussed, and also then we have some findings. There you have a blood pressure, you listen to your heart and stuff like that, and for certain questions or some visiting reasons that they come, then you should do some sort of stuff, and whatever comes up with the history that you obviously hopefully that you have written down perfectly. Then you should have done this test, and then in the end, then you have the evaluation of the problem, and then you have this is what I want to do, the measurements that this is what the next step, and if you have followed the pathway of the journal.
So the discourse, discourse of the journal.
Yeah, the discourse. So if you don't follow the red thread here, then there's a flag for that. Is there something lacking? Now you said that I'm going to write a referral, and there is no referral in the system. There's a flag.
Yeah, and used to be sharp here. You could probably this auditing of the journal and the procedure check. You can do that completely anonymized. You don't even need. No. Because you're looking at the procedure anomalies, you're not looking at the actual patient anomalies. So this is also something where someone's, this is sensitive data. It doesn't have to be. We are looking at the procedure, and is the process followed?
Yeah, exactly. That's and when you want to, then if you have 10 journals flagged from several hundred, then you have time to actually go down deep in those 10 journals. Yeah. We see, this is an anomaly, and here is some lacking of something, and here is just they were.
And then they do manual checking on that, or
yeah, then they go manual checking.
So it's the typical data-intensive process to be able to scan a lot of information to then focus the human labor where it makes sense to look deeper.
Yeah,
it's to point out where the potential problems are instead of just randomizing and looking. You have a stack of paper and if you have 100 referrals or like journals, taking out 2 of them and like looking at them, and these 2 happens to be right, doesn't mean you have 100% accuracy in the
it's like a recommender systems for bad journals.
Yeah. And as you talked about a lot about Kenneth as well, like there's so much information in the journal about the doctor, because I think we as a society has this we have a expectancy on doctors to be more than human sometimes.
And as an AI system, this is a very basic system of finding the outliers, or finding the ones that doesn't fit.
I don't know. I can just give you an anecdote. I worked with a similar kind of case in the past, and that was more about trying to identify overprescription of antibiotics in dental care in this case. And we found, a number of journals that were, seemed wrong. They shouldn't really have prescribed antibiotics in this case. And then we tried to see, okay, who is the doctor of these journals that do the most wrongly potentially prescribed antibiotics? And it turned out to be a few selected doctors that did prescribe in some way. And we thought, okay, these are bad doctors potentially. But then it turned out when we asked, these are actually our top doctors, the best doctors we have. And then we thought more about it, and it turned out okay, these doctors usually get the worst cases, the most difficult cases, which is really the reason for potential overprescription. It's not really that the doctors are bad. It's simply that they
get the worst cases.
They get more difficult cases to work with. It would be, I can imagine similar kind of situation happening here as well.
Yes. But then, of course, you will find it and see to it, okay, this is something that we can go forward on. Okay, so you can see that, okay, this anomalist, okay, this doctor has a lot of other doctors that they come in and disrupt them in their work, and so they missed out something. Okay, maybe then should have a lesser workload, so they can actually be interrupted from their younger doctors for questioning.
Yeah, and if someone keeps continuing making mistakes in, for example, in one certain area, help the doctor get that course. How can we make our doctors more efficient? How can we make them more knowledgeable in order to make less mistakes in the future?
But I think you can separate these into 2 problems, because it's the deeper problem and to go to the root of the problem and fix the whole problem. But if you look at this from a pure administration and manual work, and we want to augment people's workflows, we can then basically say, this first step, I'm not trying to solve the last step now, because that is maybe very, very tricky to solve. But this first step, we are tying down a person, an MLA, with very simply stupid work that is still not complete. It's just stick proof. So that part of the process we can truly augment. And then the entry point is completely different. And then you have another data and another AI problem. So I also think this is a point where, when you try to fix everything at once with the end-to-end process, this is tricky. But to clearly carve out where AI is beautiful to do that, I think it makes sense how you augment the MLA workflow in a certain area.
Yeah, because what we don't do anything in particular different from the workflow that is done today.
It should have been done.
Yeah, it should have been done. For example, they are supposed to do this, and that's what I said before about the unrealistic
expectations.
Expectation on doctors, because you can't do it. It's impossible. It's too much work.
Can I say, how do you try to evaluate or get the model to understand the flow or the discourse of the journal? Have you pre-annotated a set of really good ones and bad ones, or
because I set pride in giving the best journal ever. No, just kidding. But
your own, say, okay.
My own.
Okay.
No, we trained the tool for all my journals. That was some of those that I was particularly proud of, and that it has a real good flow. This is something that I'm proud of, and also I have looked at some of my colleagues that this is a really good doctor.
So you're the good example, and the colleagues are the bad example.
No. I just have good colleagues, of course. But I do a mock-up with a journal that's lacking a big chunk of information.
So you're removing some parts, or
yeah?
Okay, I see.
So do they see the gaps?
Yeah, of course.
So diffusion.
It's not diffusion. It's potentially a data augmentation, I would call it.
Yeah, but then we can make it in some way. So we have like a typical journal, and then we make the model look to a lot of just random journals that we don't have any say in, and then so here is something that maybe they're good, maybe they are not. Let's see how it will.
Then you classify it to like good or bad.
Yeah, in several different ways. If it's there something lacking, or that is something needed to be done. I think they have a graph on this somewhere. Yeah, so we
like a number of different classes.
different classifiers.
There's so many things to see and to evaluate in a journal as well.
Yeah, but if there's large oversteps or wrong steps in the journal, then of course it's a really big red flag, and you have to look at this, says the system. But if there's just smaller ones,
and then how is this augmenting? What's your idea of how to get that back into the MLA workflow? What is the UX, or how would the MLA now use this tool, or what's the thinking here?
Well, the thinking is that it should be the MLA has to work to see the already written journals, but if we can get the system to go closer to the actual meat of the patient doctor meet, then we can have a proposition after the work day is done. So I'm sorry, Dr. Kenneth, you're done for the day now? Yeah, okay, I'm done. Okay, so maybe you should look into this and this journal, because I think you're lacking something.
Because you can, in the end, interactivity, proactivity,
yes,
catching it on the fly even.
Yeah, on the fly.
So the MLA workflow can go from a more policing in the end to a coaching, proactive, a different workflow in the end.
So in the best way, there's no person that actually goes through and knock me on my head. It's the system itself.
The system itself.
Yeah, well, that's the problem we saw as well. It was so randomized, and there were so many journals that didn't get the MLA to have a look at it, and therefore the problem is already done when it comes back to you. Yeah. So like if you miss a serious symptom, you will find out by the patient coming back and screaming at you later down the line. Yeah,
or when it's something that actually happened, and there's another doctor down the line that actually found my fault, my error, and report me, and then I have to stand up and defend myself what I've done wrongly. Or
so this is then when you were really talking about data and AI allows us or gives us the opportunity to really reinvent the workflow. So the MLA workflow is there because we have a symptom in terms of how we need to treat data. If we reinvent it and can treat and manage and find and check it AI-wise on the fly, then the whole process is different. And that whole role is different. It's very interesting. Yeah. It's very telling. Because I think a lot of times we are trying to fix an old analog process instead of reinventing how the workflow would be if you're AI and data or digital first. Like you just did now as a good example. It would be in the system. It would help you.
It would help you instantaneously. And there is some models that actually try to do that, and some journal system that, here's when you have prescribed this drug. Do you know there's an interaction with this other drug? Oh, this is nice. I didn't know that. I didn't know that the patient actually had that drug. Why not? Because this is a different journal system. So in the end, when all the AI can actually find every information about one certain patient, then with other journal system and other systems that is outside their firewalls. Okay, then we have a real good thing, and the patient care or the patient security should actually be heightened a lot. But then, okay, there is a lot of obstacles on that way, but this remains to be foreseen.
But it's also the kind of mantra of our company as well. How does it fit into the process? Because we talked a lot about there's a lot of companies that I think has damaged doctors' willingness or trust in tech companies, because there's often a lot of tech companies that come and say, well, we had this fantastic new product and it's going to revolutionize everything, and you test it and it's not what you really expected. We had this really big case down a few years ago when this company overpromised. It cost the region, I think it was region Skåne or...
we had the last one now in Västra Götalandsregionen and in Borås. I'm from Borås, you know.
Yeah.
So that has been all over the news in last year. The millennium.
Yeah.
Cool stuff.
It's time for AI News, brought to you by AI8W Podcast.
Yes, so this is a small section in the middle of the podcast where we take a break from the discussion about how AI can revolutionize healthcare and speak about some exciting news in the world of AI that we have potentially seen. Anyone that wants to go first? Do you have any news that you'd like to share?
Something you followed up on or you read on?
No, we talked a little bit about it before, but the articles I think that we wanted to focus on is the thoughts and the general expectation of AI in healthcare, and what are actually people saying, and why are they reacting to it, why are they maybe not as open to AI in healthcare as it can be. And I need to see if I find the study I was looking for. Yeah, it was an article about saying that AI is like an overambitious med student, and which was kind of funny, I thought. And it talks about why AI can't really do what the doctor does, because there's so many processes that the doctor do because of experience and all these kind of things. And I think it's kind of telling as well, like we talked a little bit about that before, how can we integrate into the mindset of doctors to be open for the idea of opening their hearts to these systems that we see can help them by gaining their trust and showing them that it's maybe not the workflow that it is today, but we need to accumulate to the work process with the technology. So, yeah.
Well, my take on that is that I think all over, if I go to the industry and Data Innovation Summit, in the ambition to sell the tech, to make the license sell, if I'm really brutal, the vendor wants to, we put a lot of emphasis on the tech conversation and making it, maybe we do that really, really well. But what you're highlighting now is that the implications and knock-on effects of everybody needs to change, like what we talked about before. Doesn't make this as an easy tech buy that some technology department can buy and then the other ones can use. You need to line up all the different things in order to make this work. And I think in healthcare especially, I think that is how it should be. And we really need to take a step back and stop selling in the wrong way or approaching it from the tech angle alone. Or we need to respect how difficult it is and then work the real process. Like we said, like with your Mac, the problem, if you're going to succeed, you need to work the whole chain.
Yeah.
And I think that's what when people are saying or shying away, I think they're doing it in a healthy way because they can immediately spot that this sales process was not professionally done. It was not a 360 view.
No.
If I take the Millennium example, I mean, like I have followed it on afar, but it was clearly documented concerns from many different angles, what was not clear, but where the technology department or the project leader decided not to listen to that. To me, that is a one-sided question in a 360 journey, period. It's not sold in the right way.
I think it also speaks to, how hard it is to just find value from AI, and what so many companies do so wrong. I mean, they, for one, conflate what it means to build an AI product like Maly or something, or Millennium, to actually building a product that actually is something that is of value and can be used. But that's not enough even to have the product. You need to actually have an onboarding on that and being able to do the change management to make them use it. If you don't have all these kind of three phases, it won't actually be used and it won't bring value. And then so many people think like, now I have a working prototype. Okay, good, I'm done. And that's like not even 1% of the work, I would say.
Yeah, but let's continue this rant, because the reason, one of the main reasons why we are getting into these problems is because the steering of how we source and procure. So if we source and procure where we are not allowed to talk with the right people, but we are supposed to talk in a certain way with filters in around, and we in terms of one objective we are trying to measure, actually puts ourselves in a situation where it's impossible to win. It's for anyone. Yeah. So then you need to reverse, and you need to go back to what is it that we need to engineer for, or what's the objective function here, and therefore how does procurement needs to work, how does sourcing needs to work. If we have a cross-functional problem in order to solve here, and our processes are, one discipline at a time, a tech discipline procuring for doctors, is madness, right? So here now we need to reverse engineer. Okay, cross-functional in order to make that work. What does that mean in terms of how we do in procurement and sourcing? So there's like just the knock-on effect on the knock-on effect of an old world model. And when people then cry out and say, this is not going to fly, I think they're right. I think you need to fix the right problems.
Yeah. Yeah, to figure out which the problem is in the first hand, of course.
Which is the cross-function. I argue then, like tech and domain working super close together, not in different silos.
I would say, like for our company, we had a very long research and development phase, and I think the reason why we wanted to spend so much time on the products and involve and not just be tech interested guys, we wanted doctors, we wanted the people who actually use it to have a lot of say in how it develops. And as I was touching a bit on before, I think we as these kind of tech providers need to regain the trust of doctors in a lot of sense, because there have been a lot of cases where a lot of things are just forced on doctors and nurses and healthcare professionals in general are willful people.
Very strong-minded.
They are very strong-minded.
Awesome. Any news from you, Kenneth, or should we?
Anything you picked up on?
No, not lately. Was actually on an affair in Kista for a few weeks ago, last week, I think. There was a lot of talk about the AI in healthcare.
Please, that's news. Which fair was it? And what
EHR.
EHR, yeah. And what picked up, what is your key takeaways if you want to share the news or the buzz from that fair?
The buzz? Well, I think the overall news on that was that there are a lot of apps and there are a lot of smart thing to make you live at home more and to be cared for at home. And also there is the workflow should be easier for the doctors. There are a lot of discussion about that and how you can manage to be a healthcare professional and also be an entrepreneur. So there was also a lot of discussions on that.
Did you feel that you were on point?
I was on the right place.
And that you were what you have been thinking is on point where the conversation was going.
Yes. So
that's nice.
Yeah, you have a lot of different pain points on the way of the journal for the patient from sitting at home and at the kitchen table and discussing with their spouse or something. And then in the end product, and they have gone from the pharmacy with some prescription or just actually getting it into work. So on that way, and And also there was a lot of discussion as well that maybe not AI, but it is AI. When you have a patient in a care home and then how to monitoring them. Okay, give them medicine. Okay, who should be monitoring that? And so they actually take the right medicine. That's one thing. And the other thing is to monitoring them in their own flats. If they actually go up to the loo or if they fall down during the night, how can you see that? Is there is a pattern how they walk? So they have like monitoring that. Okay, so the last time she went up, she went in this direction. Now she's going that direction. Okay, now maybe it's not going to the toilet. Okay, so maybe she have to interact. So that one was really cool. And
so much technology that could be augmenting and making our care so much better.
Safer. And easier and more safe, I would say.
More safe. Yeah.
Lots of potential. Lots of opportunities for entrepreneurs.
There is.
Henrik, do you have anything?
I'm sitting here with the OpenAI search mode, and I'm sitting here with Gemini. Do you want to take them?
Oh, okay.
I mean, one of the things. If we go straight into the AI soap opera, they made search available quite freely, OpenAI. So OpenAI has had, they've launched, in several steps how you can do search. So OpenAI is has a fundamental search, like competing straight with Google. And this has gone, from paid subscriber now to actually something you can, without having any subscription, you can start going into OpenAI as a search engine. That was one thing. Do you want to comment on that?
We can continue on that, actually. So one news from just a few days ago was OpenAI released something called Deep Research.
Yeah.
Which is, you could argue, a continuation.
We haven't even talked about that one yet.
No, it wasn't released until a couple of days ago.
I forgot. Let's start there. Have you heard? This one is good. Yeah, start there.
It was released by Google Gemini for quite a while back, like a month ago. But now OpenAI also released and even used the same name. They at least have different names, but they just copy from each other, without any shame. and then
why should you?
Yeah. Well, anyway, it's a cool thing. And if we were to quickly describe what it does. I didn't have access to Deep Research because you have to have the pro version of ChatGPT, which costs $200 a month. But it's going to be released also for Plus users, etc. soon. But anyway, I did experiment a bit with Gemini's Deep Research, which is not as good as OpenAI's, but still. And what it basically does is, if you take the normal web search that you spoke about, which has been available for some time, it's basically, when you search for something and realize, I don't have this in my built-in parameter knowledge, I need to go out on the web and search for some more real-time information. It does so, and then it compiles it and presents an answer. But if you were to do a more, like say you do a market research for how could I sell Maly to a lot of hospitals, and then you want to figure out, what's the best way to do that. And to do that, it's not sufficient to do a single web search for that. You may need to go out and look for 50 websites. And they need to compile it together in some way. And then in the end, you may want to have a report. So this is, in a sense, doing what a lot of analysts are doing. It's building a report and literally creating a PDF or a Word document with a lengthy report saying, this is the conclusions for how you should go to market with Maly, for example. So I experimented a bit with it. I mean, this is also in the direction of agentic work. So besides having a tool, the tool in this case is the web search. So you can augment the normal LLM or foundation model with a tool like doing a web search, but it can do so in multiple steps. So then it takes like a number of steps. It uses the tool time and time again. And then it finds out, it's not enough information. Then without asking the user, take another decision. Let's search for these websites as well. And when it's done with that, and have completed the plan. First, it actually sets up a plan, and then it executes, and then it does another plan, and then in the end, okay, now I have enough information. I compile it down to a concise and nicely written report. I did it. We have a thesis student at work, and she's looking more into value capture from AI assistants, chatbots, and these kind of things. And so I simply told the Gemini Deep Search to say, okay, build a report in Norwegian in this case, because she's from Norway. And in a Norwegian thesis master student report style, and see what the challenges are to do value capture from AI assistance and potential benefits of doing so. And then it looked up 41 websites. It found similar kind of reports that have done similar kind of research in the past, compile everything and present the report. Actually in Norwegian, which I don't understand, but still, I had to ask it afterwards to translate to English. But still, it was very nicely formatted in the style of a Norwegian master thesis report that you could submit, and then the master thesis project is done in. Actually, it took 20 minutes, but still, 20 minutes okay for half a year of work.
Okay, and 20 weeks instead. Yeah,
20 minutes. Yeah. I hope you see the point. It does multi-step actions using tools like web search that is moving in the direction of agentic, even though it's rather simplistic agentic work. But it does deep research. And
a deep secondary research, or whatever you want to call it.
Secondary, what do you mean?
So, I mean, like primary research, setting up tests and experiments yourself. Secondary research, compiling what other research is already out there.
It doesn't do any experiments, no. So it's just compiling. Background research, literature search.
I've seen the word secondary research used for that.
But kind of cool. Could be useful for you as well, potentially, I guess.
But okay, so that was a fairly big one. You know, what was the sort of, okay, I used to go into the sort of soap opera. So what was the general reflections that you picked up on when they launched research? What was the general buzz?
I wasn't super impressed. I mean, it's rather simplistic and obvious kind of thing. You take web search, which is a tool. Yeah. You use the LLMs, you build up a plan and build a report. It's something that is not that super complicated. It's just adding like a agentic framework around it. I saw that Hugging Face, is a big AI platform that have a lot of models, open source, etc. They try to reproduce the work of deep research in 24 hours. So they try to build their own one, just put an agentic framework around it and use the web search. And they got some rather far in 24 hours in reproducing it. It's not on the same level as OpenAI, of course, but still it says something, but it's not super high innovation height, so to speak, in this one.
Okay, but let's go into Google now. We have Google 2.0 Flash, Google 2.0 Pro Experimental, Flashlight. Do we have we any view of what this is? This is fresh off the press. The latest release from Google.
Go into smaller models and more efficient. And I think everyone realized that the super big models of trillions of parameters is too expensive when you have hundreds of millions of users using them. And then feeling a bit of a threat from DeepSeek, and they have to have some smaller models that are cheap and not too expensive to run when you otherwise can just download an open source model and run it for free. I mean, it's
but bottom line is used at an accelerated pace. Tweaks and feature, we are literally in the DevOps cycle now of any software that gets better and better and better and more advanced.
Yeah.
And the only way to really keep track of it all is when you're in such a tool and really use it extensively to understand what's happening. You need to get your hands dirty is my point to follow this.
But what your take on DeepSeek then? You want to go there?
Yeah, we can go there because there. I mean, like, I think we talked a little bit about it on this podcast.
In the last 2 weeks, we spoke about it. But I'm getting increasingly tired of it. But yes, let's go there.
But I think it's important because I think you said it well. But if you're looking with the real people who has the deeper knowledge of this. It's more media hype than what it really is.
It's even worse than that. It's fake media news.
Yeah. There are many. We are comparing apples with pears. Like a simple topic, we say, we build something for 5 million and they build it for 100 million. It's not even true because you need to look into Anthropic. What was their original model training and what was their inference training? Yada yada yada. So you need to compare apples with apples. Already there, that is completely wrong. And then you need to look at the starting point for DeepSeek. They didn't start from scratch. Most likely, we know think that they have started out of something. They have started on the baseline of OpenAI is the general consensus. So they've been cheating.
Oh, they're cheaters.
No, then I would
actually, if we take the pros and cons here very, very briefly, for one, they did distillation from OpenAI, meaning they didn't train from real data. They trained from really high quality data from another frontier model. And they were examples like if you asked DeepSeek, what's your name of the model? They said OpenAI. Okay. So, very badly distilled and stealing data from other frontier models, which of course makes the data size much smaller and more efficient to train. They also didn't have any vision support, which both GPT-4o and o1 has, which they don't. And that reduces the size of the model significantly. And they didn't spend only $5-6 million. They spent hundreds of millions of dollars. But still, they did some innovation. I wouldn't take it away. I think, they had actually some awesome stuff with the way they did reinforcement learning, the way they use Python code to validate through the steps if this is an accurate solution or not. And they actually did a lot of innovative stuff, really low, very close to the hardware, so to speak, in how to make this really efficient. And that also tells me it's perhaps a bit more people involved in this than people think.
Okay, but what does it all mean? And here we have a debate. But my take, where I completely share me and Goran share this view, is that what is very interesting and positive about this is that it truly shows a way. There is a game to play. There's a position to play, even if you yourself cannot master to build a frontier model. So it's a little bit like, what should Europe do? What should Sweden do? We're screwed, right? We can never do what OpenAI is doing or stuff like that. And now, from a media perspective and getting buzz, someone was doing something that we now have picked apart. It was way simpler. And actually, most of the research they did it was already out in open papers. So then I get, fuck, man, you can make a big splash here with what we know in Sweden and with the competence we have in Sweden. If you use smart enough, savvy enough with your marketing, cynical enough to steal with pride, instead of us saying
but this is actually literally illegal because it goes against terms of service.
Yeah, but I think it's completely bullshit to when one guy who has been stealing data from all the other guys is pointing finger that you are stealing my data.
But you couldn't argue the efficiency.
I think it's bullshit that Sam Altman can say you have been stealing my IP. That is the dumbest thing he could ever say.
The efficiency argument doesn't hold anymore. So they're not more efficient because they steal from really high quality data from someone else that trains something.
Yeah, so we're getting into deep argument on the how big was the, they shouldn't have done that. And I say, look beyond that. Just look at these fundamentals. Building standing on the shoulders of giants, stealing smartly or even legally.
Say the big innovations here is really, that they did put it out open source, which is an interesting take, and you can think about why, and then you get into more political kind of reasons for this. I tried myself, of course, asking, what happened in Tiananmen Square, and of course it censors that, and that could be some other perhaps reasons for them putting this out there, to actually influence a lot of opinions, but also to gather data or whatnot. So, we have to be a bit more.
Yeah, that's what I'm thinking about it as well.
Of course, yeah, and then of course it's always the whole game. You want to destroy the moat that the other guys are playing. So if you are not if you're number one, you want to be proprietary. You want to lock it down. If you really want to take away the competitive advantage of OpenAI, make it open source, and then compete on another level. So those things
it's a
are
lot more than media portrays about this, and it's a bit annoying to see how much misinformation and disinformation that is being spread about this.
But generally, I find it super positive because it shows a position where we can play, and you can play really, really well. Don't just try to go out and do this. Don't try a game that you can't play. Find the game that you can play.
Yeah.
The new space race, it's called.
Sorry?
It was called the new space race of AI.
Yeah.
It's been around for a long time. It's a big AI race for many years now, I think.
Well, what was your
Goran,
take?
did you have...
Goran.
But there are a few actually that I think is good. One is Peter Sadin. So there's a couple of news actually which we are missing on top of this. So
we know that Google released Gemini 2, right? Then in Peter Salin from Silo AI basically is going to lead the open source AI initiative in Europe for 56 million. So Europe is investing 56 million on top of all the AI factories. I was actually speaking with, it doesn't matter today, but it was interesting that Finland is investing far more, almost 10 times more than Sweden is due to invest in AI. Which is very bad for us. And the interesting thing is now in this OpenAI Kardashian drama that we are on to still. So Sam Altman, as you know, they have started discussing like, hey, shit, man, we have been a little bit wrong in not being on this open source race. We should have done that in the beginning and stuff like that. And then, of course, he was involved in making a 500 billion project, right? Where Oracle, him, and a couple of others will dedicate 500 million, right? Billion. Great. So if you have those money, why are you asking another 40 million in funding? They're just basically talking about taking a 400 million in funding, potentially rising valuation 340 million. That is how you get your extra 100 that you want to invest. So it's very interesting. And then it was another thing that was very, let's leave it like that. I think it's, we are looking at the race from a frog perspective. And I think that there are very big moves that are happening on a very bird eye perspective. And we are not looking at it. We are just jumping as a frogs from the ground. So like, yeah, whatever. So that is from the news from my side. We talk a little bit more next week.
I think we'll leave it. Any comments, last finish?
OpenAI need money. I mean, they're not going to pay the 500 billion for the Stargate.
They have a lot of customers. They make 3 billion last year in revenue.
But the inference cost that they have is insane. They're not making a profit, right?
I don't need a microphone for this. I heard a very, very nice saying. It has always been the case that the second mover has the bigger advantage than the first mover. And I don't understand why people are so angry at basically that DeepSeek and many others that will follow on this, they will capitalize on what the first ones did, right?
Obviously.
Why? So this is the opportunity for us in Europe, in Sweden, in the Nordics to be the second movers and not look from a frog perspective again. It doesn't matter. Let them build the foundation models. We will build vertical AI on top of that.
Yes, that's
right.
That's great. But
you can see how we're getting into the debate.
You can't really say that they did an innovation or did anything, very spectacular if they just build it top of an existing one. So that's what media gets wrong. Then if you should do it, I don't care about that. But don't say that they were as good or something.
No,
right? But we still can innovate on top of innovation.
And that's what we should do.
Yes, please.
Yes.
And that I wish what EU will do and what Peter will do, and not do the idiotic thing of training something from scratch again. That would be, don't do that again. That's the stupidest thing you can do, right?
Yeah.
Okay.
So there's not going to invent the wheel again, right?
Yeah. There's no point. I mean, building a foundation model is not actually that hard. I wish they spend money on, what is hard, which is really how do you adapt it to your needs? How do you do the proper continued pre-training, or how do you do the supervised fine-tuning on the data you have, or how do you preference reinforcement learning on top of this, or how do you do the reward-based reinforcement learning to have your kind of use or your kind of data in the way that you want? This is much more advanced and much more useful to spend money on.
And there's a bigger debate in Sweden.
And they steal data from models.
It is the bigger debate in Sweden is how should we spend our money? Oh, we need to build our own frontier model. Really? Is that what we're going to spend our money on, or are we going to build baby models based on someone else's frontier model? Are we going to fine tune it for different verticals, stuff like this?
I think in your case as well. I mean, if you were to use the which there are coming really big models, that is going to be super expensive, and if you put them in production, it will be super expensive to use, and obviously that would not be, I think, for you the right way forward. You would have a more specialized model that is tuned for your needs and at a suitable size.
Yeah.
Yeah. And this is what most products and application will be in the future. And, that is what we should be good at. If we are great at that, that would be an awesome future, I think, for Sweden.
Yeah, so this whole topic becomes like...
Another interesting for you
is like this was an open source, so you can download it, right?
Which one? DeepSeek.
DeepSeek. You can download it and edit it and make your own vertical one, right?
Yeah. Fine tune it. Yes. Yeah.
Fine tune.
But if OpenAI kills their service, will DeepSeek work?
No, they couldn't retrain it anymore.
Yeah, but will this version work?
Yeah. I mean, they still have the knowledge in it, but they can't update it.
So let OpenAI burn their servers and we'll make innovation on top of them. What? Let them burn the money. Let them build foundation models. We build on top of that. What?
Yeah, that is how we should do it. It will be like a handful of frontier models in the future, like 5 of them or something. And then we distill data from that to train other models and fine tune it for our needs. I think what the future will be. Yes. We've been saying this in the future, or a couple of times in the past. It will be a few frontier models, but thousands and millions of smaller models that is actually being possible to use.
And in practical terms, the cost to run the frontier model on a microservice will most likely be too high anyway. Yeah. So you're doing that in order to build your model. And then that you can use an open source framework. You use Llama, whatever. And then you get to a point where you do the beta model, fine tuned for a very specific purpose that you can then run at a drastically lower cost. So the trajectory where this is going, I think it's fairly obvious, because you get to a point where people are just staring at the frontier models, and it's like there is no practical use in a device Anyway,
okay, good.
Sorry, that's a rabbit hole today.
Yes,
I thought it was going to be short.
You open a rabbit hole there.
Yeah, sorry. I had the opportunity.
He didn't know where he's getting himself.
No, I realized that after a while.
Anyway,
well, it's good. Thank you. Yeah.
Did you? Yeah,
I learned a lot. Yeah.
Did you learn some?
Yeah.
So, Carl and Kenneth, working in the medical field with AI and tech in general is hard, I guess. And what would you say that the biggest challenge is to really do? Yeah, I hear something.
There's a phone that is on voicemail and going around.
That was my fault. Sorry.
Yeah.
I didn't even. I didn't hear it because I'm in the headphones.
Yeah. Anyway, there are a lot of challenges, I guess, to really put AI systems or tech systems in general, or IT systems in general, in medical field. What do you say the biggest challenges are? What have you seen so far, and what's your thought about really making sure that they find value, that they are being used in?
Well, in general, the largest is the tech. Not awareness, so to speak.
The
lack of awareness, the illiteracy.
The resistance.
And the resistance, but the resistance is based on fear.
Yeah, illiteracy.
Illiteracy and fear. But they go hand in hand. It's something that you are afraid of, you don't want to actually...
Why do you think they're afraid about AI? Is it because they think they're losing their job? Or why would they be afraid about this?
There's a lot of discussion of that okay, some way in the future we will be out of a job. Yeah. But then some voices raised in the no, you have to have someone who actually see if this process is hallucinating, or somehow to actually take a hand on the patient, and so you have somehow to guide them through this. So maybe our role will be a bit more of a guidance counselor or whatever, but our use in the medical society will be there. I'm positive of that, and it must.
And if we really, how can we even think like that when we at the same time talking about that we are swamped in administrative work?
Exactly.
So how can you take those two arguments at the same time? I really think it's
we are really complex people. Yeah.
No, but I mean, and we are talking about the whole. If I go to the public sector and elderly care and all that, we can see a shortage of 30-40% of the workforce going in retirement, and we are not seeing the same numbers in new recruitments.
No, not at all.
So we need to literally flip 30-40% shortage to tech.
That's why don't we do it?
So why don't we do it then? Yeah. And then you say that the major hurdle, one of the major ones, it really starts with education or learning to get it into your comfort zone.
Yeah, to get in the comfort zone and have used it, and people who have used some of the tools that we have now on the market, they don't want to go back.
No.
So why should I write my own journal again?
Yeah.
But I think you are on the money here, because if you have knowledge on the deeper level, then that knowledge disseminates out into the different disciplines that needs to work on this: the regulatory dimension, the safety dimension, the adoption dimension, the engineering dimension. But it really starts, in my opinion, if I then take that as truth, this is a literacy problem. What is then the real problem?
Money.
Is it really money in healthcare?
Fun and time.
Yeah, it takes time and money, of course, as well, to actually prove a point. If you have a proof of concept that you want to engage in some way. Okay, this is something that I'm burning for this. This is something that actually will renew the work that we have here on this premises. Okay, and okay, how much will it cost? Is the question. Not what would the benefit be. That's not the question. So they put it everything. The manager of the healthcare center says, okay, how much will that cost a month for me? Okay, but not the benefit it will make. But
I want to test something with you.
Yeah, sure.
And you will follow me when I say this, because when I think of this knowledge gap and the way I've been failing to communicate my way through this, I come to one single conclusion. There is only one way, and this is learned by doing.
Yeah.
And ultimately, we get to the famous Spotify quote: "We should be the fastest." We should be the company that fails the fastest.
Mm-hmm.
Spotify, Daniel Ek says it, and of course it's about fail fast to learn faster, right?
But you can't really compare that to medical, because we can't fail at all.
Yeah, you can.
Yes,
but then so if you understand that the main problem is
I'm aware, I'm on board, but not general.
No.
Because take an example. If you take Neuralink, and speaking Elon Musk here, and they actually literally put chips in the brain and do operations in a very regulated medical field, and they move very fast and do human trials at a pace that I think no one else is really doing, even in this kind of very difficult field. So I mean, I think there are ways to do this.
So what we're talking about here is to be precise on what is the problem to be solved, because I think it starts with acknowledging that it's an education or it's a literacy gap, and then if we have been in the field, we have understood, all of us, that there is only one way to do it, and this is experiment. And
I'm on board with you guys. But that's why I'm here.
No. So what I'm saying is, then, if we're going to talk to our politicians, if we're going to talk about how to invest money in this, I would be very, very scared if someone did a huge AI investment program at this point in time that looks like this as a kind of big bang approach. I would rather want to see investing heavily in how do we do safe experimentation, how do we ease our way into this, so spending a lot of money but in the right way. That's what I'm trying to get to.
But we also have I think, I'm not sure who said it, but I think he spoke about the opportunity cost of not using AI, and he phrased it in terms of healthcare and for administrative tasks, which I think you can use as well. He said, one way to phrase is, we're going to make medical doctors 10% faster, and they're going to do less boring work. Okay, that's a sales pitch. Not a very good one, potentially. But if you instead say, we are, by doing this, not going to have 10 people killed or be dead, because we can actually spend time on patients instead of in journal systems. That is a much stronger statement, right? So you speak about the opportunity cost. If you have to spend so much time doing administrative tasks instead of helping patients, people are going to die.
Yeah, I think a lot of doctors are just also tired of being told to be more effective, because you can only beat the mule until it dies. Yeah. And that's I think we would like doctors in medical professions to be more open to AI, but they are skeptical, and we need to find out why are they so skeptical. And they have been burned so many times with the next new thing, and that's why I think it's very hurtful when a lot of companies just rushes in with new products and doesn't do the homework like in the way it should have been done.
The change management that needs to be placed there.
So let me try another one, because I'm working on exactly the same problem, but in enterprise. And we are talking companies like Scania or Tetra Pak or something like this, having the same problem of adoption. Why doesn't it happen? And a few people knows about it and sees it and is on board. And here I can kind of pinpoint another problem. I think it stems from education, but it moves into a very strong topic of the way we have organized our competences has been in separate disciplines rather than cross-functional teams. So if you go and look in detail, how is Spotify organized, how is Klarna organized, how is it digital native organized? So even if they're digital native and it's all tech, when you really scratch the surface, they are very clear cross-functional teams. This is the data scientist, this is the data engineer, this is the behavioral science psychologist, this is the UX person, and this is the product owner. So you have a completely different way of how you have organized the competences. So you build away these communication gaps or lingo gaps. Yeah. So I think it stems from competence, but that competence then takes the one drawing the org chart, the one setting up the operating model, the one making the budget between tech and business. It needs to change. So all that thing is blocking.
And I have another take on this, the problem, if I may.
Yeah, please.
Yeah, I think this also is the lack of time.
Yeah.
If you have the time to actually test something, if you have the time and energy to actually, this is something new, I want to test this. Okay, I take the day off now and just dig into this. But what about the patient? Who will take care of my patients that day? Well, no money. Okay, then because I can't afford to have a temp that day. So that we have a problem. So we need to have people who have the time or make time to actually look into something new. And that's a bit rare in this slimmed organization. So we need more money to actually put off the
money. I mean, it sounds like they need to take a leadership course and think about what the growth mindset is versus the fixed mindset.
Yeah,
but I can let's run with your comment. And a nice word to describe this is using the word slack. If you use the word slack, you need to have, in order to innovate, there needs to be slack in the system.
Yeah.
And if you use that word, if you Google slack, there is so much research on this. Another key topic that we are describing, which is different in a digital native, you have the development and operations in one. So there is slack in the system to innovate, to develop, and to operate. What we have been trying to do in the medical field or in the old analog places is like, this is the line organization, and here is no slack. Now we put up programs and projects on the side. Here we have billions of money we are investing in the Millennium Project that then is trying to move in that way. And so it's a completely different way of spending. The same money could be reallocated as slack and investing into the core business or the core verksamhet. So it's also, this is a reallocation of steering of resources of innovation.
Still, I worked a bit with medical fields as well, and I think there are a lot of doctors that are very, very interested in this. Very,
there is. Fortunately,
sure. Very interesting. So I think there are examples of this. And
but they're working against the system. They're working against the system. They don't have any slack. They don't have any money. They need to talk. If they want to do tech, then there's someone else they need to talk to. So everything is stacked against the innovation. That's what I'm trying to get to.
You haven't mentioned regulation, by the way.
No, that's what I also top of my mind now. So regulation, you are bound to do certain stuff, and you're not allowed to do other stuff. Because if you do that, then the regulation will prevent you from actually having your core business working at all.
So time is flying away here. We could speak a lot about regulation. I think we've done it so much, I don't think we need to go into it. And I think everyone knows that regulation in the medical field is even harder than in a normal field.
Yes.
It's not just GDPR anymore that you have to follow, but a lot of other regulation as well, which is tough, right?
That is.
Anyway, I think it can be done. I think it's with the right leadership in place, we could actually make this happen. And I've seen it happen in places. So I think it can.
Hope you're right.
With that, perhaps thinking and moving a bit to more closer to the end kind of topic. But what's next for Mediqtech? Can you speak a bit about what the coming roadmap for 2025 would be? Or what's going to come up now, coming months and years?
We have a lot of interesting projects going on. It's unfortunately a lot of things. The customers we have talked about, we have signed NDAs, so we can't really go in too much about it. And there's a few things we're actually doing now that we haven't seen anyone else done or figure out. So I don't want to go with too much in detail and spell out the secret sauce, so to say. But I think what we're trying to do now is just looking at the market, because
what is the market, by the way? Is it Sweden mainly, or is it other places?
I think Sweden is the main market, and I think you can always in the beginning you play best at home field. So like perfecting and getting our products in a way that we really think that doctors can use, because if you see how the doctors react to a lot of products that are being pushed to the market, they are merciless in their criticism. And I saw the comment about a big product being pushed to the market now, and the doctor's comments were something in the line of the more a person needs to use AI, the more the lack of natural intelligence.
That's so stupid.
Yeah, and so it's those kind of hurdles. I think we need to work around, and I keep circling back to getting the trust of the people using it, and the mantra of Mediqtech, but finding our place in the workflow.
Yeah, you need to have ambassadors on those places. I think that's
change management.
Yeah, change management is one thing, and you have to have someone who actually have used it and just stand on the forepost. Okay, here I've tried it, and I'm a doctor, and you know me, and I think this is working. Get on board.
Exactly. Yeah. And speak about opportunity cost, perhaps, and say, who do you think in 5 years will be winning? Is it the one using AI, or is it the one not using AI? I think the answer is very simple.
Yeah, of course.
It's a very simple answer to that, right?
Yeah, but the thing is, we have
twice the many patients.
We've been speaking to a lot of regions, and we were so close in getting our product into one of the regions, and I don't want to shame them, but
not yet.
No, not yet. We'll maybe there. Maybe one day. But everyone was so on board in the product. We were clear for the lawyers signed off on it. The doctor said they want it, and then when we wanted to push into to the region, they said, well, this kind of product can air out our dirty laundry and show all the mistakes we're doing. We don't want that to be. We don't want that to be out there.
Our legacy. Yeah.
Yes, and we were like, "Are you serious? Is this why you're stopping the product? Because you see the value, you can see the potential of saving lives, and
that's actually a very horrible concern.
Yes,
and a reason to stop.
Yeah,
that is really cynical.
Yeah, we were kind of like. That dropped our jaw a little bit. That was the reason. But
perhaps you can, rephrase the way they do it and make sure it is there for helping people or medical doctors as well. It's not about, finding problems. It's about helping them, coaching them.
But it makes it so clear navigating the messaging and taking away their concerns so they don't end up in the tabloids, if that's the biggest concern.
Yeah, but that's
then
the thing.
This is fixable, of course.
Yeah, and that's the thing, and that's something that we have seen a lot, and we need to focus on that part of it. There's a very few benefits of being first and being innovative, being innovative in healthcare. We see that. Because there's so many things that can go wrong, and there's very little upside to you of being first, because you get a little pat on the back, and the risk is getting fired and being shamed. Mm-hmm. So I think one way to push innovation forward in the medical field is for someone to benefit from it.
Find value,
find value and lower the threshold, lower the risks.
But get the right people, because there's a lot of people saying things and are the voice of the AI from the healthcare's perspective that have no clue what AI is about. They think they're AI experts because they attended a 3 months course.
I've seen that.
Been there, done that.
There's quite a bit of that, and that is actually is that a problem in itself that we have now all of a sudden a lot of self-proclaimed AI experts, and they have opinions and they've done good work, and in very much things it's great because we're building momentum, but the risk, I guess, can be that we're getting on the wrong train. So we're doing it in the wrong way. Like you said, like someone is pushing product in the wrong way. Or, I mean, like we have another example, your CEO goes to a course and someone shows how easy it is to put together a ChatGPT setup for your own personal productivity to make invitation for your children's birthday, right? And then then the core problem with that is how hard can it be? And they think that it's a quick fix to get it done in the enterprise world or in the real world, when in reality, you need the data, you need the all the stuff that you guys are working on in the back end is almost unseen. And all of a sudden we get to a very dysfunctional perception of what you should be working on and what you should be doing. So this is what I think is with the trickiness when so many people are also standing on the hype, but not really knowing the full length of what they should be doing. We should be doing.
But I'm sorry that you have NDAs and can't speak about it, but it sounds good that you have a lot of plans, at least coming year, I guess. Yeah. Awesome. And to end with our standard question, and being a bit more philosophical as well, do you believe AGI will come, by the way? A time, if let's say we define AGI as the time when an AI system can be equally good as an average coworker, a medical doctor or nurse or whatnot, meaning literally not only understanding text, but actually being able to take action and do the work that a human could do, which they vary from today, I would say. But still, if we assume AGI means being on the level as an average coworker, do you think it will come?
I think it's unavoidable to some stage. Like, I am an AI optimist.
Of course.
Yeah. Well, I wouldn't be here if I wasn't trying to push it on these medical professionals if I wasn't. But there is this concern. It feels like that we are all going to be this fear of being replaced, and you have this one group of people saying that, well, if all the boring jobs and all the things we as humans don't need to do anymore are taken over, there's so much more time for us to be our true selves, and we can go hike every day and we can do all these things that we need to fulfill our lives. But what are the purpose then of human existence if you do, like, because if we go into my personal beliefs, it's just to strive to something that makes you to go forward. Like, what makes a person want to wake up every day? It's to develop and do things that are important and hard.
Yes. Let's not go that too, because that's a follow-up question, basically.
Okay.
Do you also, Kenneth, believe that it will come at some point?
At some point, yes. But as a medical doctor in a general practitioner's office, then there's a lot of levels of that knowledge. And it's not, I mean, you need to have like a robot doing the things. Yeah. So you have to have the physical person that actually walk around and do something.
Yes.
And then, then we have it. Then there's, of course, in so many levels that I was thinking about when do people accept a robot to do this?
Yeah, exactly.
The pat on the shoulder and maybe do an exam of the belly or do a pelvic exam.
But I really like, Anders, you have cooked together some sort of different levels based on whatever other people there are definitions of levels of AGI. But I really like the ones we've been discussing where we talked about
the 3 ones.
Yeah, the 3 or 4 maybe with societal, maybe the top one. But you have said about first we have the knowledge, the fundamental knowledge.
Oh, you mean the OpenAI's levels of AGI?
Or you said, yeah, maybe it is. But you talk about, I think sometimes about, first we have used cognition.
Okay.
And that we can ask, and actually the cognitive level is as any coworker.
Yeah.
And then you get to maybe to digital digital work. So digital work where you at the level of a coworker of actually taking action, but your main interaction today is a screen. And then you get into, so you can do stuff, right? But you can only do it in the digital space. And then you have the third level where we have this sort of the real actuations, physical AGI, robots. Yeah. And then you actually mentioned the next level from the robots to societal AGI, where it's accepted.
Yeah, a disruption in society.
So and of course here we have the this is the first level is almost there. The second level not so far away. The third level with robots, it's pretty far away. Yeah. And the societal, it's generations away most likely.
Not generations, but
no, I think so because I think it's about. The newer generations this will not be a problem for the iPad iPad babies. Won't have the same problem with that in 20 years.
But it's also that organizations are very slow. So even if we have the technology there, it can work both in the perception space, in the digital space and physical space. It still wouldn't change how Karolinska Institute work potentially. It will take a lot of time for them to change the way they're working, and that will take 5-10 years.
Yeah, so the societal topic is that then we have fundamentally reinvented everything. And Carl-Henrik Swanberg talked quite well about this when we have also on Data Innovation Summit. He was arguing that when he was the CEO for Ericsson, we had a fairly good idea of how we thought this would play out with IoT or digital, blah, 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 blah. And we were envisioning not too far away from where we are today. It's the same like internet and all that. We could see it in 99, but it took us 20 years for the fundamentals to have reshuffled, so to speak. And this is what we're talking about again.
Yeah. Okay. Anyway, assume at some point, X number of years in the future, we will have AGI. We can imagine that becoming in the 2 extremes and a spectrum between. But one extreme, of course, is the Matrix and Terminators of the world and robots going rogue and killing all the humans and whatever. And then the other extreme is more toward what Nick Bostrom now wrote in his latest book, Deep Utopia. We're moving to a utopian future where AI have solved cancer and AI have solved climate change and energy needs, and we have fusion energy and it's free for everyone. And we basically have a world of abundance where goods and services are free to use. That could be a utopian, at least for some people, I think. Where do you think we will end up? What's the most probable place if you rate it from 1 to 10? 10 being
dystopian to the real utopian. Dystopian to utopian.
Kenneth, if you start.
I can start. Well, I think I'm liking the idea of a utopia. So it's been so I'm leaning on utopia thing. So maybe
for just because you have the hope, or because you really think it's going to happen that way.
Oh, I'm really hoping more than actually believe it in my core, because people are a bit.
People are weird.
People are people, and people are weird, and people are mean.
And the world is going in a strange direction.
Yeah, it is in a real strange direction. So maybe if we really put our mind into it and really have the path lined up to us. Okay, so and then I will gather we might end up in utopia eventually.
So 70%, 90%?
Yeah, 70%.
70%.
Yeah.
Awesome.
What about you?
A few weeks ago, I went to a seminar by Hans Rosling's son. The son's name escapes me now. But we are so programmed to think that everything is going to be so bad all the time, and just the human bias of everything is going to shit. But we have survived.
Actually, that is. Someone said that is how we actually survived. That we always are thinking about the risks.
Yes,
for the mammoths.
Ola Rosling.
Yes, Ola. Yeah, that's his name. And they have this. They pull down the pants on everyone at the lecture and saying, because everyone took a test, like how is the world going right now? Is there more wars? Are people dying? All these kind of very Rosling kind of examples. And people still, even people who work in medtech, and I think you are very educated on the business of how the world is going and developing, are very negative on how the world actually looks. So I have hopes. I have high hopes for the future. I think we will get into the.
Good for you.
Yeah,
that's good.
Yeah,
awesome.
No, but I think, I mean, like the tricky summary of this is, I think the book is not written, so it's all about how we as society, innovators, politicians, that we take charge of where we want it to go. So sometimes I also think the debate is a little bit like everybody makes themselves into a victim. We should forge this destiny. And I think that's the main.
Make our own destiny.
We should make our own destiny, right?
Isn't that the saying? You know, the best way to predict the future is to build it.
Yeah.
So if
to be it.
To be it.
Awesome. Yeah, awesome. I hope you can stay on for some more after work and off-camera kind of discussion and going even more into more philosophical topics. But thank you so much, Carl-Fredrik Swic and Kenneth Ilvall, for coming here. And best of luck with your very societal benefit, work that you're doing, trying to improve and revolutionize healthcare with AI.
So basic good ideas.
Okay.
True heroes.
Yeah.
True heroes.
True heroes.
Here.
Thank you.
Thank you.
Thank you.
Thank you.